you, Ren. Any questions for the panel?
What's the difference between the triphasic and quad? I'm still confused slightly.
Yeah, so the quad has that early phase. So if you're suspecting pseudoaneurysm bleed in the liver or hepatic arterial bleed, you can ask for a quadruple phase. So they will do that very early 6-second one, which can capture a quick, like a brisk bleed.
Renu, I have a question. What would you do about albeit rare but more complicated scenario of bilateral lesions? Maybe they're big, maybe they're indeterminate, but they're bilateral and resection's not an option.
Any lesion or adenoma? Or
maybe you're deciding between, maybe you have indeterminate Eovis study, no central scar, 4.5 centimeters, 4 centimeters on the other side, 5, whatever you want to say, and there's not certain diagnosis, but resection's not really going to be an option there.
So we have a study that we had done from Mayo that's unpublished because we were trying to get a multi-center data on adenomas and looked at adenomatosis, which is a condition where there's multiple, more than 20, but you do see 2 adenomas or 3 adenomas. And we saw that 20% had 2 different kinds of adenomas. One of it was steatohepatitic adenoma, and the other one was a beta-catenin positive. And it's difficult to convince anyone, forget the radiologist or the patient, to biopsy both. So in clinical practice, I try to biopsy the larger one or the one that's more suspicious. So for adenomas, those that have steatosis, like I showed, those have the LFABP positive, those are generally benign. The risk for HCC is very low. So if I see that one is steatotic or inflammatory looking, because the radiologists have some signs for telangiectatic adenomas, that lesion I try not to biopsy, and if another one looks relatively, doesn't have these 2 features, inflammation or steatosis, then I'm worried for beta-catenin positive, which is what we want to pick up. So that one I would biopsy. So just biopsy the larger lesion or whichever is more concerning.
In men, any size needs to be resected or symptomatic?
So in men, the studies are few, but the conditions which cause adenomas in men, MODY or glycogen storage disorders, those have a much higher proliferative index and higher risk for HCC. So when we had the data that we have had around 25 men, and I think 5 of them had progressed, so that's 25%. And most of the data is all case series because adenoma is rare and is very, very rare in men. And when it happens in men, they have one of these, either MODY or glycogen storage disorder. MODY is maturity onset diabetes in the young. So in men, any size, we recommend resection.
Neil, I have a question for you. This is not in regards to liver cancer, actually for alcoholic hepatitis, since you have a consortium. You guys are transplanting alcoholic hepatitis, right?
We are not.
Oh, you're not.
We are the, so UCSF is like the organizing center. So there's about maybe 30 to 40 centers in the country now that are transplanting for severe alcoholic hepatitis based on this Franco-Belgian protocol that came out 5-6 years ago. So we're kind of staying out of it for now and kind of, kind of being the organizing center for data collection and dissemination. But so far we haven't decided to start transplanting people with alcoholic hepatitis.
Okay, then I'll not ask the question.
I'm still happy to, I don't know what the question is, but I'm be happy to try to answer it if it's, but I think certainly the field is changing. And I know a lot of the centers that are here, we all have different kind of protocols, but I think the idea is really, instead of using a kind of a formalized 6-month absolute cutoff, to really start to, just like with everything else, to try to risk stratify, right? Not everyone who's been sober 3 months is this, or 1 month is this, so I think we're, all the centers I think are thinking about it right, and so, but I think the field is kind of moving towards maybe if we think patients are low risk for recidivism or lower risk than transplanting them rather than necessarily waiting 6 months.
Okay.
I have a question about HCC. Your surveillance protocol after transplant is more nuanced than ours, but even with just 2 subsets, which is what we do, we still ask the question, does it change survival? And so I'll ask that question to you.
Yeah, so...
Why so many categories, and does it change anything?
Yeah, so We don't, that's a great question. We don't know. We're studying this right now with the help of Dr. Guy and about 6 or 7 other centers in the country. And really the question is, does earlier detection of recurrence matter? There have been a few studies now that have shown pretty nicely that HCC recurrence is curative, in that you can actually, it can be cured and you actually can get 5-year survival after recurrence. The data is mostly based on time from transplant to recurrence, what's your AFP at recurrence, and was your recurrence basically either resectable or ablatable. So kind of features that make sense. But so I think there's a notion that if you can detect recurrence earlier, patients can have a good outcome. Obviously there's some bias with, lead time bias, but we're studying this idea. So basically you're now, in your centers included, but we have about 8 centers. We're getting every single patient with HCC. We're collecting them at the time of transplant and then prospectively studying them moving forward with a retreat-based or a risk-based surveillance and trying to determine if it's cost-effective, if it's going to be, if it's actually going to help lead to kind of better survival.
Any other questions? Stanford.
Yeah.
Yeah.
And then there's some in Southern California as well. But yeah, so Stanford for sure. And then Cedars-Sinai. I can't remember about kind of UCLA and Scripps what they're up to, but I know Cedars does as well.
I think UCLA is.
And UCLA I think just started as well. It's coming. Eventually, I think it's already kind of 35 out of 130 centers. So it's already almost, at some point soon it'll be a good chunk of centers. For the first few years, it was mostly centers in kind of regions that were looking for patients. So patients where they had lower MELD scores at transplant. But now you're seeing it more and more kind of throughout the country. So Mikhail's asking about GALAD. So there's a few scoring systems that have come out, BALAD and GALAD, which utilize these extra tumor markers we were talking about, the L3 and the DCP, along with one of them is used to determine kind of risk of HCC development, and one of them is more of a prognostic model. We typically don't, we're not really getting L3 and DCP on every cirrhotic. We're really only getting them at the time of diagnosis, really. But we use it for prognosis. We are really thinking about it more in the concept of transplant. I don't know if you guys are using it at Stanford or CPMC, but I think we're really trying to figure out how these markers can be useful, whether it's in screening or after diagnosis in terms of maybe picking the right therapy or prognosis. But so we don't commonly calculate it and then talk to patients about it. Remind me. No, I would love to. I'll go Google it now. But no, it's fine. I don't know if anyone else in the group knows more about it than I, but I will have to learn about it. I'm intrigued.
Okay. Thank you, Renu and Neil. Excellent talks.